chromosome 20 interested me since a long time. It is a rare disorder, but it has many features that, if unraveled, might really help to understand many other forms of epilepsy, because it has inside many different features that are important for many other drug-resistant epilepsy. Ring chromosome 20 was first reported in 1972, and up to now there are about 150 cases reported in literature. Up to the 90s, the cases were all reported by geneticists, and the features of epilepsy were rarely mentioned. The ring chromosome is best diagnosed, as you will hear later on, with a chromosome analysis in peripheral blood, and array-based techniques, the ones that we use more now, are the miss in many cases the disease, because when we have to deal with the mosaicism and with the chromosomes that don't miss any part of the genetic asset, you will not see anything wrong. Chromosomal mosaicism is very frequent in ring chromosome 20 syndrome, and it means that only part of the cells have an altered genetic asset. The patients that I will discuss in my presentation are all patients with a mosaicism for ring chromosome 20. I start with a few definitions that I think that everybody knows, but I think it's better to go through them. When we discuss an epilepsy, we need first to see what kind of seizures are the clinical manifestations that are different in different patients. And the seizures are due to an abnormal and excessive excitation and synchronization of a population of cortical neurons. We deal with ring chromosome 20 with the focal seizures that originate within networks limited to one hemisphere. They can be limited or they can diffuse in many occasions. And we speak about epilepsy when we have more seizures that are recurrent spontaneously, that are not provoked by systemic or acute neurological insults. This is the typical thing that happens to an epileptic neuron. This is the first one is the normal discharge that we can see when a neuron work. And in epileptic neuron, we have these discharges that are excessive and go on for a longer time than what is the usual. In ring chromosome 20 syndrome, we often have difficult to treat epilepsy, and we often have a difficult an epileptic status in many of the reported cases. I think that one of the important things that neurologists should know, neuropediatricians should know, is that we have a distinctive EEG pattern that is, it might be useful in making the diagnosis. Intellectual disability is not a feature that is present at the beginning when we first see our patient, but it's at some point, not really a severe one in many cases, but it can appear later on. We have also behavioral disorders, and we don't have dysmorphic features that are typical of the syndrome. Why I say that? Because usually when we see intellectual disability plus dysmorphic features, that's really a drive to make genetic testing. Now genetic testing are more widely used, but here we still need some testing that is not the one that we do in the modern times. Neuroimaging is normal, so it cannot be useful to make the diagnosis. I say that there are no typical dysmorphic features, so dysmorphic features of the face, but sometimes we see something, and sometimes in in the papers are reported rare malformation or behavioral disorders that we will go through later on. This is the normal EEG of an adult patient. I just show it to you to see at a glance how it is different if you see the EEG in a patient that is an adult here with the ring chromosome 20. You see that is different, the activity, the background activity. This is not a seizure. This is an interictal EEG, what we call, so that's the EEG that we see between seizure. It has a typical trait that should be well known and looked for by the neurologist. This was the paper where we first described this activity that by chance we saw in a mother and a child that had the ring chromosome 20 syndrome. And then a few months later, we saw the same activity in another patient, and that really made the drive to make the diagnosis. This is another example, and also this is an example of what happens during sleep. Then EEG, it's important. EEG is the electroencephalography. It's the recording of the electrical activity during wakefulness and sleep that can be really, really useful. Epilepsy. The age of onset of seizures is reported from the first day of life up to 24 years of age, with a peak between 5 and 9 years of age. Behavioral disorders are often reported before at epilepsy onset, and many times nightmare, terrors, hallucinations are reported by patients at the onset of epilepsy. Seizures are special ones because seizures last longer than usual. We have often what we call non-convulsive status epilepticus. That is a situation where seizures don't stop after a few seconds or minutes. Seizures they have a way of starting, a way of propagating, and a way of stopping usually. And that stop comes a few minutes after the beginning. But here we have something that goes on, that doesn't stop. Then we have also focal seizures during wakefulness and sleep that we will see later on. We recently reviewed 25 patients, and we also reviewed the cases that are reported in literature. And we found 25 patients, not that many, from 6 epilepsy centers in Italy. So we have the impression that is underdiagnosed because if you go to centers where the diagnosis should be made, we find still a few patients with ring chromosome 20. It's a rare disease, it's true, but the impression is that it's not diagnosed enough. I must say also one thing that could be a bias because we collected patients from epilepsy centers, so patients that might be more severe than other cases that may be treated more easily. This is always a doubt we have when we look at patients that are collected in third-level centers. This I think is something that is very important because it can be missed as a psychiatric symptom, something that is not really an epileptic symptom. And these are visual hallucinations that are not easily found in other epilepsy that we see. Patients report to see huge spiders, sharks, monsters, or they see people that are known people in a different way. They say that they see thieves, they have the fear of bombing, something that is really changing. And it's these are seizures, that the beginning of seizures in many situations. The other important feature is the presence of nocturnal frontal lobe seizures. Frontal lobe is a huge part of the brain, a very important one, and it has the possibility of making many different types of seizures. Seizures in frontal lobe often are seizures that occur during sleep, and they can be also very, very subtle. So if you don't make a recording, you can miss the seizure because they can look as a normal arousal. The non-convulsive status that was described by Inoue, a Japanese researcher in the 90s. As I said, in non-convulsive status, you can have some symptoms that can be recognized. You have an altered consciousness in many situations. You can have a stargazing, oral and gestural automatism, and many times, but sometimes later on, you can have also some myoclonias that occasionally can also involve upper extremities, meaning that you can have jerks of upper extremities. The episodes are recurrent during the day, and they can last from 20 minutes to hours. In some patients, as I said, the symptoms are really subtle, and epileptic encephalopathy, a concept we will go on later to better understand what we mean, may be associated with the onset of non-convulsive status epilepticus. In the patients that we followed up in our series, non-convulsive status was still present in all patients where epilepsy was active. We have 25 patients in our series, the recent one, and 5 patients are well controlled, they don't have any seizure, and 20 still have seizure, and when they have seizures, they have the non-convulsive status. There is a circadian pattern. What we mean by circadian? That there is a fluctuation of, there are moments where it's more frequent that you can see, where you can see seizures and you can see non-convulsive status. And this can happen more easily in the evening or when patients are tired in the late afternoon. And I mentioned epileptic encephalopathy. We described for the first time 3 patients, and we saw that this is more frequent, that began to have seizures with many seizures, a situation that was an electroencephalogram that was completely disturbed by a pathological activity. And this was a situation that compromised the intellectual abilities of the patient. This is a girl that now is 21, but we met her when she was 9. She was really good at school. She was dancing. She was horse riding. She was perfectly functioning. She went away for a vacation in summer, and when she came back, she began to have episodes at night where she was like with night terrors. She was afraid that the house was going to be bombed. She said that she saw thieves thieves. You say that in the house, and. After a while, she began to have seizures. Her neuropsychological assessment was really bad. We tested her for everything. We tested many drugs. And at some point, we made a karyotype, and we found out that it was ring chromosome 20 and mosaicism. And valproic acid and lamotrigine were the true drugs that at that point seemed to work really well because they stopped at least the seizures during wakefulness and stopped that continuous epileptiform activity, and she began to have again a good relationship, and she could speak, and she really regained points at her IQ, and she got better. We know epileptic encephalopathy is in many other situations, but we think that in some of the patients with weak chromosome 20, especially when they begin in a time frame that is around 5 and 10 years of age, that's a time frame that is very sensitive to epileptic encephalopathy. And that's a situation where we should start very fast to treat, to regain a normal EEG, and to have a good answer in our patients. We saw two other features that were not reported in literature. We found 2 patients where seizures appeared after hot water bathing. That was not reported in literature, and 1 individual was photosensitive. In 2 patients, psychological fatigue or emotional stress was a trigger for non-convulsive status. In the long term, as I said, 5 patients had a favorable outcome, and 19 had still seizures. I forgot to say that one of our patients is followed up since when she was born, because she had a prenatal diagnosis of ring chromosome 20. She's 9 years old. She's perfect. She doesn't have any seizures. We don't see any abnormality on the EEG, and we are following her up. In conclusion, onset of rapidly and severe seizures, especially with frontal lobe features, in a child with no dysmorphic features, with normal or only mildly delayed developmental skills and normal brain imaging, should make the physician consider ring 20 syndrome. About half of the patients experience seizure worsening and cognitive decline that persist until epileptic encephalopathy is controlled. And patients with epilepsy onset at an older age tend to experience a milder course with seizure remission in the long term in some individuals. And this, again, is the same thing, and I thank all the people that work with me on this matter. I hope that it was clear. I tried to show you the main features of epilepsy in this syndrome. Thank you.